welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today we have Christine Hancock, who is an emergency medicine resident at the University of Michigan Health. She will be presenting a journal club on epinephrine versus norepinephrine as initial treatment in children with septic shock. Thank you.
We'll first start off by just talking about background, and this will basically just go over definitions, and this is going to focus on pediatrics or children. And so definition in terms of septic shock, this is a severe infection leading to cardiovascular dysfunction, which may include hypotension, impaired perfusion, or the requirement of vasoactive medications. In terms of management, it's very general, but typically requires antimicrobial therapy within the first hour of recognition, as well as fluids. And this is typically a 40 to 60 milliliter per kilo over the first hour, and this is done in boluses of 10 to 20 milliliters per kilo. Vasoactive medications may also be considered in these patients, as well as stress dose steroids. A very quick review on our vasoactives and our adrenergic receptors. And so we have our alpha and our beta receptors. We'll start off with alpha-1, which is primarily located in the vasculature. And when these are agonized, the response is vasoconstriction. With alpha-2, primarily in the CNS, as well as the vasculature, which can result in sedation and vasodilation. For beta-1, this is primarily located in the heart, which results in inotropic and chronotropic effects. And lastly, with beta-2, primarily in the lungs, with resulting in vasodilation or bronchodilation. And so for our two vasoactives, we're going to be talking about our epinephrine and norepinephrine. Epinephrine is primarily beta-1 and beta-2 with some alpha-1 agonism, but primarily beta agonist. Norepinephrine on the other side is primarily alpha-1, but has some beta agonists as well. And so in terms of previous literature, especially in our pediatrics, very limited data, but there have been some literature in the past that have discussed vasoactives in pediatric patients with septic shock. And so this randomized control trial by Ventura and colleagues looked at dopamine versus epinephrine as first line in pediatric septic shock. So they looked at dopamine compared with epinephrine with a primary outcome of a 28-day mortality. In terms of the results, they saw that 13 deaths were in the dopamine group and 4 deaths in the epinephrine group, which was a statistically significant difference. And they determined that dopamine was associated with increased mortality in pediatric patients with septic shock used as first line. And so what do our guidelines recommend? And so as we know, there are the surviving sepsis guidelines. There is the pediatric version and the adult version. And so in terms of our adult version and the data we have, their recommendation is to use norepinephrine as first-line therapy. But on the flip side, in terms of the pediatric surviving sepsis guidelines, they suggest using epinephrine or norepinephrine as the first-line therapy compared to dopamine. And this is all provided based off of weak recommendations and low quality evidence. And they are unable to provide a recommendation for a first-line vasoactive for children with septic shock. So that is where this trial comes into play. And so this is one of the first studies that have looked at epinephrine and norepinephrine, and specifically in pediatric septic shock. And so their objective was to determine whether receiving epinephrine compared with norepinephrine as that first vasoactive medication administered is associated with improved outcomes among children with septic shock and those who do not have known cardiac dysfunction. And so going over the methods, this was a single center retrospective observational cohort study that looked at epinephrine and norepinephrine, and it was done at one pediatric hospital in Boston, and looked between June 1st in 2017 and December 31st in 2023. They did not report any funding for this study. In terms of patient criteria, we're focusing on pediatric patients. So they looked at patients who are 1 month to 18 years old who presented to the ED with septic shock that did require a vasoactive medication. In terms of their exclusion criteria, they excluded patients who had known cardiac dysfunction or those who were admitted to the cardiac ICU. And they mentioned that they excluded this because they thought that it may induce provider bias in terms of selecting a vasoactive option. They also excluded patients who had a vasoactive that was not norepinephrine or epinephrine, so that included dopamine or phenylephrine. They also excluded those who had non-sepsis indications, as well as those who received intramuscular epinephrine, which meant that patients potentially were coming in with anaphylactic shock. They also excluded those who had a cardiac arrest prior to starting a vasoactive and those who were already on vasoactive medication when they were transferred to the ED. Based off all those exclusions, this inclusion left 231 patients. And so their primary outcome was a composite, and this was the MAKE 30, or the major adverse kidney events by 30 days or hospital discharge. And this included a composite outcome of death, new kidney replacement therapy, or persistent kidney dysfunction. And this is a validated outcome. In terms of secondary outcomes, they looked at both 30-day and 3-day hospital mortality. They also looked at initiation of extracorporeal membrane oxygenation, endotracheal intubation, as well as the individual components of MAKE 30, including persistent kidney dysfunction or need for renal replacement therapy, as well as any additional need for vasoactives or steroids. They also looked at mechanical ventilation or ICU and hospital-free days. Big thing that we're always wondering about are adverse effects. And so they assessed for presence of tachyarrhythmias associated with medications. And they did this by identifying patients who were administered the following medications, which included adenosine, amiodarone, diltiazem, propranolol, sotalol. And this was identified at any point from starting the vasoactive and until discharge. In terms of their statistical analysis, they summarized categorical variables using frequencies and percentages, as well as continuous variables were summarized with medians and interquartile ranges. They used the chi-square test to assess primary and secondary outcomes, as well as the Wilcox and rank sum test for continuous variables. They also utilized an inverse probability weighting system, which I will talk about in the next slide, and propensity scored analysis. And so what is the inverse probability of treatment weighting? And so the idea behind this was to adjust their results in terms of potentially having confounders and to adjust for that fact. And so each patient is assigned a propensity score representing a probability of having that outcome. And so they did this by determining patients using their age, presence of a sepsis risk factor, first blood culture positivity, time from ED arrival to first vasoactive, the highest phoenic sepsis organ dysfunction score, as well as bolus amount before vasoactive. The results of this analysis did provide an average treatment outcome. And so going over the results, we'll first talk about the baseline characteristics. And so in terms of their median age was 11.4, 54.6% were female, and 61.5% were predisposed to sepsis. And so some other things that I wanted to pull out from the baseline characteristics were the time from arrival to vasoactive initiation in hours. And so you'll see for the epinephrine group, it took 3.6 hours versus a norepinephrine group was 7.5 hours. And so it was longer to start norepinephrine, and this was a statistically significant difference. In terms of ED start of vasoactive, meaning that the vasoactive was started while the patient was in the ED, there was more in the epinephrine compared to the norepinephrine group, meaning that there was more epinephrine started in the ED compared to other locations in the hospital as well as the ICU. And this was a statistically significant difference. And then lastly, this wasn't statistically significantly different, but in terms of the lactic acid, that was slightly higher in the epinephrine group at 2.1 compared to the norepinephrine group. And so I'll first just talk about the unadjusted outcomes and results, primarily looking at the primary outcome of MAKE 30. Looking at this, we see that in the epinephrine group, there were 9 patients. In the norepinephrine group, there were 3 patients. This was not statistically significantly different based on the confidence interval. In terms of 30-day and 3-day mortality, they saw that there was no mortality in the norepinephrine group, but there were 6 in the 30-day group and 5 in the 3-day mortality group. And this was statistically significantly different. In terms of the other secondary outcomes, there were really no difference except for the number of additional vasoactives, which they did see that there was more vasoactives needed in the epinephrine group. And so going back and looking at our adjusted outcomes, we talked about our inverse probability of treatment weighted outcomes. And so very similarly, they looked at our primary outcome and our secondary outcomes. And so for our primary outcome, they saw that there is maybe a 2.1% increase of MAKE 30 in the epinephrine group, but this wasn't statistically different. The only thing that was statistically different was the addition of vasoactives, and they saw that there was an increase of 24.6% in the epinephrine group. And then lastly, in terms of our other secondary analysis, in terms of mortality, they looked at 30-day mortality, which saw a 3.7% increase in the epinephrine group, which was statistically different. And in the 3-day group, this was not different. Going back to our adverse effects and seeing if they had any tachyarrhythmias, they reported that no patients in either group received any medications to treat a tachyarrhythmia. And so we'll talk about the discussion and first just quickly review what the authors concluded. And so they concluded that norepinephrine was associated with similar rates of MAKE-30, but lower mortality compared with epinephrine. And so overall, the study suggested that norepinephrine has benefits in terms of mortality, but not the renal component. And so in terms of evaluation of the study, in terms of its strengths, we'll first talk about how the baseline characteristics were fairly well balanced. They did attempt to adjust for confounders in their statistical analysis, and they did have a very strict inclusion and exclusion criteria to kind of help mitigate the provider bias depending on the patient's clinical presentation. In terms of limitations, I'll say the biggest one that the article does actually briefly mention is that they do not report time to IV antibiotics or fluids. And the biggest thing that this article does talk about is like the potential for confounders, but this is something that I wish was reported out for each group to kind of see, like, is there a difference or was there a delay in antibiotics in one of the groups, and was that contributing to mortality? The small sample size, as well as the retrospective nature, as well as potential for unmeasured confounders or any sort of markers of severe illness that are missed. In terms of the tachyarrhythmias and their identification, they only utilize medication administration as a way to identify for any of these adverse events. But it would have been helpful to potentially see if there were any changes in heart rate or anything like that, besides just looking at medications. They also did not report doses or duration of vasopressors, but they did state that they just utilize a standard order set that we're likely all familiar with. And they did not identify types of infections. They did report blood culture positivity, but did not identify those types of infections. And so what are my final thoughts? Kind of like, what do I make of the study, and do I really have a decision? But I would say for now, there are a couple questions that I would like answered before I can fully make a decision on what is kind of the best first-line vasoactive. Like, were patients in either group sicker? Like, how long did it actually take for antibiotics and fluids to start in both of the groups? What infections did these patients have, and what were the doses of vasopressors? And I feel like just having this reported out as like a general kind of thing for us to evaluate, I think may provide some more depth to the study. And these are my references. And that is the epinephrine versus norepinephrine study. Happy to take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.